Thank you very much, Dr. Chopra. We're going to go ahead and commence with the arterial session. The venous session has already started, so those that are interested in going into the simultaneous venous sessions, we'll start that. I'll have Dr. Paul Jones and Miguel Montero Baker are going to be moderating the aortic disease session. We'll get started here pretty soon.
Good morning. I'd like to welcome everyone here again for day 2 of our program here. We had a phenomenal day yesterday, and certainly we would like to continue along the same vein there. This morning, we would like to begin the first session of our aortic disease program here, and we are fortunate to have again one of our distinguished faculty members here from out west, Tucson, Arizona. And Dr. Miguel Montero Baker will talk to us about abdominal aortic aneurysm size, a suboptimal way to determine the risk for rupture. Dr. Montero.
Thank you, Paul. And again, thank you to Jaafer for having me here this year to follow. I guess this is the clicker. We live and die still today by looking at a CT scan and deciding when a patient needs to be treated based on what I would say to a certain extent we ourselves have created, and that the insurance companies has also utilized as means to determine when we have to intervene in AAAs. I think aortic aneurysms, we need to understand that the development and rupture are a result of the interaction of biologic and biomechanical alterations that lead to remodeling and degradation of the extracellular matrix. It seems like a complex array of things happening to try to oversimplify it with a ruler in our computers at the hospital. So I like this quote that says, "Abandon the urge to simplify everything, to look for formulas and easy answers, and to begin to think multidimensionally, to glory in the mystery and the paradoxes of life, not to be dismayed by the multitude of causes or consequences that are inherent in each experience, to appreciate the fact that life itself can be complicated or complex." This is complex. I think AAAs and how they work is complex. The classic and simplistic approach that we still use and die for is trying to push the law of Laplace, which is made for rigid structures that behave outside of the body, and mesh that with population-based data to come up with this very simple answer. If your belly aneurysm is 5.5 or above, I'm going to fix you. If you're 5 or below, I'm not going to fix you. And if you're a woman, then maybe 5 or above, I should fix you. But we're ignoring the fact that there's complex geometry, presence of mural thrombus, calcified plaques, and then the hemodynamics that come with that. So, of course, you're trying to get this image from our physics book back in college to apply to a human being that has, like I said, multiple complexities. So if all AAAs would look like this and would behave like this, then things would be simple. We wouldn't have to simplify things. They would just be straightforward, but they aren't. They sometimes have calcium, and sometimes have mural thrombus, and sometimes they're elongated, and sometimes they're not fusiform. So let me just point out some of the things that go against just using this as our bar. So wall thickness, there's no significant relationship between AAA size and wall thickness. You can have a really small AAA that's thick, and you can have a really large one that's thin as paper. And thicker walls are associated with diabetes and slower expansion. Wall strength, the aneurysmal growth is associated with a reduction in tensile strength as a consequence of progressive elastin and collagen degradation with metalloproteinase activation. Women have weaker aortas. And ex vivo data demonstrates that ruptured AAAs are weaker than an elective AAA. So there's something to say also about the characteristics of the wall. And we've gone back and looked with ultrasound at compliance measurements of the wall. And just through a very simple B-mode ultrasound, you can demonstrate that the aneurysmal walls are stiffer than a normal aorta. So that beautiful pulse that you see on a transversal B-mode, you don't see that on a AAA, likely due to the decrease in their elastin. And then ruptured AAAs have lower stiffness than an elective AAA, which would go against kind of what we're saying, but it isn't, because it's the point at which there's a failure of the protective remodeling process that makes the wall thicker and stiffer to prevent rupture. Growth patterns of intraluminal thrombus are a better predictor of rupture risk than diameter itself, since the thrombus reduces the pressure transmission to the wall. So just including that fact into your mathematical algorithm, reduce the wall stress by 1/3, and adding calcium then lowers the compliance of the wall and increases the stress up to 20%. So what would be a more realistic and more accurate prognostic model? Well, anisotropy is pretty much the preferential stiffness of an aortic wall in one plane, understanding that there are areas of the aorta that might behave different from other parts of the wall, and that these models are more sensitive to those geometric factors like length or asymmetry, and that actually changes our decision making. And mechanical response, the viscoelastic property of the wall that counteracts the stress, and how aortic tissue doesn't respond in a linear nature like you would expect a physics model on a back table in our labs. So the old linear computations would overestimate your rupture risks, and it's not a one-to-one. And on top of that, you don't add the stress and the shear stress that comes with the peak systolic pressure of a person. So it also has to be involved, the hemodynamics that come with it, since you have to measure all these when the peak systolic pressure is happening. So certainly computational wall stress analysis makes sense, and that's where the finite element analysis has come into play. We have been doing that for many years, and we have been able to do it in a very reproducible manner and in a very automatic manner, and it's less time and labor intensive. And so there's no need to simplify the problem, but we can just create the tools to expedite the process in getting all of those variables into one decision. So this is what it does. This is what finite element analysis does this. It grabs a CT scan and it creates this mesh and it chops it up. And depending on some of the variables that you give it, then it's going to create a color scheme of where the wall stress is and where potential areas of rupture will come from. I would say Fillinger is probably one of the persons that has most researched this area. And this is a very nice paper back from 2003 where he showed a very interesting fact. Looking at observation AAAs, elective repairs, and ruptures, let me put a couple of lines on that. The smallest AAA that ruptured in that series was 4.4 centimeters. So I put that line at 4.4 centimeters to show how 90% of those that were being observed were all above 4.4, but yet 4.4 ruptured. But then look at the peak AAA wall stress below. I put the line where that peak stress wall on that particular patient was, and see how all that have been observed are about 75 to 80% below the wall stress that that particular patient had. So even though this might be a small number, because of course, the bigger the aneurysm, the most likelihood that the stress on the wall is larger. And that's why we've gone by sizes, and it's worked. But there's about 20% of people that won't fit into that profile. And there are small aneurysms that have high wall stress. And there are large aneurysms that are horrible, and they're 12 centimeters, and they have a lot of neurothrombomas, and maybe the best thing to do for those guys is not do anything. So this makes a little more sense. So what's the future for the finite element analysis? This is where we're at. The limitation is how to assume the information about the wall thickness and other material properties that come with the AAA to try to set it into a population of people that all react in different ways and that we're all unique. Because you ultimately give the CT scanner a mathematical algorithm to be able to create then the finite element analysis. But in that, you're actually creating some assumptions. And so the first AAA or the last AAA, you might not have the same material properties, and hence the algorithm to create the stress of the wall should probably not be exactly the same. And so that's pretty much where we're going, is this, some of the newer papers that we're having, where we're just looking at the model of assumptions. Is what are going to be the traits that we're all going to agree to that will allow those variables to become constants in those algorithms that will allow then the FEA to be a much more reproducible and automatic process that will allow us as physicians to take more intelligent decisions. Thank you very much, guys.
Miguel, thank you for an excellent talk and discussion. I think that's a very, very important topic. I am impressed by the fact that, again, we are looking at size alone to make determinations about treating these aneurysms, but we're clearly missing the boat in a number of these patients, particularly in women, which I think is very, very interesting because certainly at our institution, some of those ruptures that come in through the ER are not these real large aneurysms, but the real smaller ones, particularly in women. So I think, again, a lot of work has been done in that area. I think it's very, very important work, and we need to continue to go down that path. Moving on in our agenda, and he's just kind of breathing down my neck here a little bit, as usual. We'd like to invite a dear friend and colleague and an incredible vascular surgeon and certainly one of the early pioneers in endovascular therapies. Dr. Vinky Ramaya from the Arizona Heart Institute is going to come and talk to us about the update on the current EVAR devices and what is in the pipeline.
Thanks. I'd like to thank Paul and Jaafer for organizing this excellent meeting, which has really grown over the years. In the next 10 to 12 minutes, I'm going to talk to you about how to treat those abdominal aortic aneurysms. What are the current devices, and what is the future of these devices in treating these patients? I do have a consulting agreement, and I will be discussing some sort of an off-label use of these devices too. If you look at abdominal aneurysm endografting, you will see we've come a long way, right from what we used to do, thanks to Dr. Parodi and other inventors, and now what we are doing. And even this has now come to a percutaneous approach. So you don't even do incisions in the groin. So we've come a long way. And I've been very fortunate to be working at Arizona Heart, and we've gone through these devices like we go through underwear. Because some of them were really underwear. So technology is changing, and it is becoming really, really good. And future iterations of these devices will make this like doing peripherals through radial approaches, patients going home the same day of the operation. Could you imagine a day when patients come in, get the aneurysm repaired, and go home in the afternoon? I mean, we never even realized that this could be possible in the. So there are two things that you need to look at when you're treating or making aneurysmal devices. One is the proximal neck, because you need fixation or you need something to hold the device there, and second is the seal zone. So you need a segment where the stent graft can oppose against the aortic wall and seal it. So sealing and fixation are two concepts of devising endografts. So if you look at the current market right now, there are 6 FDA-approved endovascular devices to treat abdominal aortic aneurysms. We all started with Anurex in September of 1999, so it's more than 16 years now since these devices have been. And endografting did go through a phase where people thought this was a failed experiment, but now it has become standard of care. If you look at all of these devices, a lot of them have the same architectural design. The concept of fabric and a metal framework is how these devices have been made all these years. So if you take Gore, it has PTFE and metal. Cook has Dacron and metal. Endologix has PTFE and some metal. So does Endurant, and so does the lumbar device too. What I feel in this field, or in this space, is that this architectural design of PTFE or Dacron material with a metal framework has reached a peak. It's going to be extremely difficult to make these devices better and better to treat short, angulated necks. So something you got to think out of the box to make these devices work for the more complex anatomies that we are doing. So if you look at infrarenal devices, even the current devices that are coming out in the market, like the Cordis Incraft device or the Bolton Triovance device, these devices, again, have the same architectural design, and I don't think they have an added advantage to the current devices being made on the market. So you got to think about thinking outside the box, and that's what attracts me to the technology of these abdominal aneurysm devices. So how would you choose an endograft? What would make you choose to pass a ball rather than rush it when your strength has been in rushing and lose the Super Bowl? So how do you decide which device you want to use? So if I've been doing, in fact, 2 to 3 years ago, still people were putting in Anurex devices. What makes you change from an Endologix to an Endurant, from an Endurant to Anchor or to Lombard? So the first thing that attracts me, at least, is the concept of the device. So any technology, you've got to look at the concept. That concept has to be agreeable, has to be logical. Then you look at the device and see whether that concept has been achieved by this device in the market, or does it need future iterations to make that concept work? Then you look at the data. Then you look at the complexity of the device in its user-friendly way. And then finally, you use it, and you look at your own results and experiments, and then finally you adopt that technology. So adopting technology sometimes for all of us can be very, very challenging. So again, looking at all of these devices, we've been involved in all of this, right from the Cook days, right from the Gore days. And now the new concept is what's known as polymer technology. So this concept is totally different. It's outside the box. There are 2 devices. One is available on the market. One is due to be available hopefully next year, called the trivascular ovation stent graft and the Nelix device. These 2 devices have totally different conceptual designs. You basically put polymer rather than metal. So you adopt a better sealing technology, and the fixation part remains more or less the same. So the concept is very simple. You can only make these devices literally very, very small by putting it in and then manipulating these devices from the outside. And that's how the future of endoluminal stent graft technology is going to be in the near future. So you can put it through small pipes and then modulate it or manipulate it from the outside by injecting the polymer or injecting technology or injecting endobags, filling up the aneurysm sac, and that's where this technology for endografting is now headed, and that's how I got into this concept of polymer technology for treating abdominal aortic aneurysms. So I'll talk briefly about one of the devices, which is called the Ovation Trivascular Stent Graft, that is now available. It was approved in December of 2012. We started using it in February of 2013, and it has become more or less the workhorse for my particular group of patients. So it is the lowest profile device on the market. It's a 14 French OD. And we've done about 193 grafts over a period of 2 years, which is a tremendous amount of volume. And we started doing it in very short, calcified, really bad cases. And that's another fault of physicians, is when you have new technology, you tend to use it in the worst cases and then say this technology doesn't work. So you got to overcome your learning curve before you say this technology is really good, use it for the appropriate cases, and then start to push the limits. Like this particular case had access vessels of 4 millimeters and 3 millimeters, and we got a very good result. Distal aorta was about 16 millimeters or so. We got a very good result. Then I started this one, which is my second case, very short neck, and you can see angulation and a very short neck. We sealed that with the Ovation Trivascular. And this particular case was what really made me adopt this technology, was this lady with a 6 centimeter abdominal aortic aneurysm, severely calcified, creatinine of 3.4, and you can see we put this sealing ring right at the level of the renal arteries, and in fact sealed them, and she is now almost 2.5 years out. And then we started pushing the technology to all on-label, off-label, really bad cases that we were then seeing whether this device would make it. And we have done a lot of these cases, 193 of them, with very few complications. And also, percutaneously, we've been doing them almost 96% of time. So our whole practice pattern has changed. 14 French OD is literally like a balloon pump or an impeller device that you put manual pressure. So we've been treating all of these just percutaneously. We've had 4 type 1A endoleaks. We treated these with a Palmer stent, and one of them with a Palmer stent as well as some coils. And this is one of those cases. You can see very big aneurysm, very short angulated neck, very access vessels, not only small but angulated and calcified. And this patient did get an endoleak that we had to put a Palmer stent, and then we treated this. So once the device went in, we've not really had any one of them come back except for one iliac occlusion because of the ProGlide failure and no internal iliac that was open. But otherwise, the average length of stay has been very good. No secondary interventions apart from that one. No type 1, type 2, type 3, type 4 endoleaks at all. And we're in the process of analyzing this 1-year follow-up data in terms of freedom from rupture, reintervention, survival, and sac shrinkage. So this has become our go-to device. It has become the workhorse system for our AAA devices, and we are slowly adopting polymer technology in addition to other stent grafts that are available on the market. The Nelix is another concept. It's a great concept. The data is pretty good. The study has already been finished, and hopefully it will be approved next year, and this is on similar lines. The next thing that attracts me to technology is not the current device, is what can you do to make it better? Is there room for improvement for these devices? And yes, you can, because you can make these sealing rings, you can make these bags any which way you want to accommodate the second configuration of the aneurysm. Then, of course, we start to treat patients who have really short necks and really bad necks. Short of doing fenestrated cases or fenestrated endografts, our hands are tied when you have patients who are very high risk for surgery and have aneurysms that are very short and angulated with not much of a neck. And the debate goes on between fenestrated grafts and chimney grafts, and these are the advantages and disadvantages and pros and cons of using fenestrated versus chimney grafts. The biggest concern is obviously the wait time for fenestrated grafts and the skill level needed too. So chimney grafts, if you look at the data, this is not a randomized study, but if you look at all the pooled data, it more or less rivals fenestrated grafts. And if you look at 30-day mortality, you can see compared FEVAR versus chimneys, you'll see that's more or less okay. In terms of mortality and rupture, it's sort of comparable to fenestrated grafts as well as chimneys. Overall target loss, sac shrinkage, sort of almost equivalent to doing chimneys versus fenestrated grafts. If you have the luxury of waiting 3 to 6 weeks to get a fenestrated graft, then obviously this is where the technology will be eventually compared to the chimney grafts. But you've got to remember, when you're doing these chimney patients, they're obviously much higher risk. They're larger aneurysms. They're symptomatic. They don't have a waiting period that you can have the luxury to wait for. And so these are more complex patients. And our experience, which we're going to publish soon, with these chimneys versus fenestrated is it's almost comparable. And in fact, if you can design a graft utilizing chimneys rather than fenestrations with the wait time being off the shelf, then obviously that's where the technology is headed. And if you can incorporate polymer technology, because the sealing rings or the gutter leaks can be much easily treated when you use polymer technology, then that's where the technology is headed, and that's what's in the pipeline. And fenestrated grafts, everybody's doing them now. skill centers. This was a patient who had a thoracic and an abdominal and then had this huge visceral segment that enlarged, came in with abdominal pain. Luckily, we did have a fenestrated graft that actually fit him when we had it on the shelf, and then we put the fenestrated grafts and then treated the entire abdominal and thoracic aorta. But when they are symptomatic and you don't have a waiting time, then this is what you have to do. You have to get them chimneys in there and then use the polymer technology. And this is the future of how to treat thoracoabdominal thoracic aneurysms. This is what we're looking for in the near future, and it's going to happen very soon. So what we have been doing today will have to change for tomorrow. And that's where you got to pay attention to the technology, and that's how you treat your patients with the best possible options. Thank you.
Thanks, Venki. That was a great overview of what we have today and certainly the future of technology when we talk about EVAR therapy. We're going to move on now to our live case that's being transmitted from Covenant Medical Center in Urbana-Champaign, and Dr. Syed Hussain has a very, very interesting case to share with us.
My name is Dr. Syed Hussain. I'm a vascular surgeon down here in Champaign, Illinois. I work out at the Christie Clinic Vein and Vascular Center, and we are currently here at the President's Covenant Hospital doing a aortic aneurysm repair. You can focus on the films that we have already done. We've gained access to this patient already. What you can see here is we've done it percutaneously. We've got 2 perclosed stitches placed on either side, and we've already gained our access, and we did our aortogram already that you can see on the screen there. The gentleman has a 5.5 centimeter infrarenal aortic aneurysm. You can see that there's a very nice long infrarenal neck below the lowest renal artery, which is the right renal artery. And you can see that when we bifurcate down below, we've got a nice long landing zone in the iliac arteries as well. The key thing to remember as far as device selection in these patients is, as Dr. Ramaya talked earlier, there's multiple different devices that one can use to do these cases. We decided to proceed with the trivascular device. It's a 3-limb device. It's 12 French, smallest device on the market. And so trying to do it percutaneously obviously makes it a much nicer choice compared to some of the other devices on the market now. I'm going to go ahead and get started here. You can see from the photograph, if you look at the screen on the left side, you know, that's the blank screen. That'll be our live fluoral screen. And then our reference image is on the right side. You can see that I've marked some of the areas with black lines. And so when I typically do an aneurysm, I try to minimize the amount of pictures we take during the case. So often I'll do a first run with the pigtail catheter, and I'll have my rep actually go ahead and mark out the renals, mark out the bifurcation and the bifurcation of the iliac arteries as well. So if you lock your screen in place, you theoretically should not have to take any more photographs the entire case until the end. And so that's really the goal, is to minimize the case, the contrast level in these patients as much as possible. All right, so we're going to proceed with putting in the device from the right side. A lot of times when I do these cases, I try to figure out how the wires are crossing and whether or not to cross the limbs or make the limbs go anatomically correct. In this particular situation, if you look at this aneurysm, the way the wires are crossing on this patient, majority of the aneurysm is on the right side of the patient. So in this particular case, I'm actually going to leave the graft in an anatomical position.
Hey Saeed, this is Miguel Montero Baker from the U of A in Tucson. Are you going percutaneous or not? I wasn't clear on what you're doing in that sense, and if so, if you can walk us through
we are
your
going
decision.
percutaneously. We put in 2 perclosed stitches on the right and 2 perclosed stitches on the left. I usually deploy them at 10 o'clock and 2 o'clock, so it kind of gives it a nice ability for those stitches to take and to make a nice X pattern on the artery when you close the artery at the end. So you can see the device here. Tim, would you mind just going ahead and pointing at some of the key features here?
One through. Right here we got the top of the graft. So as you can see, Dr. Hussain will have to advance that a little bit north. This is our orientation mark. So you can see we got kind of a exclamation point on that right side. That indicates that that is our ipsilateral side. So as Dr. Hussain said, we're going to stay anatomical with this. So our contra gate is going to open up on the left.
So we're pulling the first step back. We basically want to go ahead and unsheath the graft. Now at this point in time, you still haven't deployed the graft. You still have a lot of room to adjust. So in the event that you're too low or too high, you can definitely manipulate the graft, as you see me doing that here. The goal is to stay below those gold markers right there. So I've already got my lines on the screen, so I know exactly where the renals are at. So I don't need to shoot any further photographs. Now I'll pull the first knob, which will deploy the graft itself.
So
you can see that the graft is deployed.
the first knob basically opens the mid-crown, and you still have room to manipulate this in terms of parallax. So you see those 4 markers? So if you really have an angulated neck and you have those 4 markers at a very acute angle, you then avoid the parallax, make all the markers straight, shoot an angiogram, and then the final knob will cause fixation. So you still have room to maneuver this endograft at this time.
So pulling the second knob down, that releases the top portion of the crown. So now you're seated, and now there's no more room to manipulate anymore. Now you're permanently fixed at that point. Now at this point in time, the next step is to go ahead and get the polymer mixed, and we'll show you how we do that here. You can focus on this side right here. So Jesse, as one of our OR technicians, she'll go ahead and actually mix the polymer. What you're seeing here is the buffer and the actual polymer, and what you need to do is to mix that about 20 times, and then she'll go ahead and give me the actual syringe, and then I'll go ahead and put the polymer in. And what the polymer will do is it will actually illuminate the rings so that you're able to see where the rings are that actually create the seal for this particular aneurysm.
So I can tell you one of the things that in the past when we've done is the painful process of allowing that thing to go in and waiting while you have to pull out jokes and kind of sit around waiting as this thing gets hard and goes inside. What's your plan on pulling that off on a live case?
In this particular situation, we won't need to wait about 14 minutes. The 14 minutes is the polymer time for it to cure. So the good thing is you can go ahead and cannulate the gate and put in your contra limb while you're waiting for that polymer to harden. So it's not like you're just sitting here not really doing a whole lot. Sometimes it can take a little time for people to cannulate the gate. So you can see me going ahead and hooking this up now. I'll take the automatic injector, please. No, not that. The injector. Thank you. Yep. So this is the automatic injector here. And if you can see on the floor now, you can see that the rings are starting to fill. So as the rings start to fill, you'll start to see a squaring off of those rings. And that gives you a nice idea that you're actually making apposition to the wall of the aorta. So we usually will wait for the rings to fill until we can see the contra gate open.
So while we wait for that contrast to go in, Vinky, let me ask you this. Since you said this is your go-to graft now, there has been ongoing debate in the past over suprarenal fixation just because of the fact that intimal growth can potentially lead to, down the line, renal flow disturbances, and some people and even some companies that don't have suprarenal fixation insist that that is a reason for not going down the path of suprarenal fixation. But now we're talking about mega suprarenal fixation, which goes all the way up over the SMA, and in a couple of cases we had it over the celiac because there wasn't that much distance. What do you think in that sense?
Well, it depends on the design of the suprarenal struts. If you look at this particular design versus, say, the Cook device, the Cook device has suprarenal too, but it has 8 suprarenal struts, which are very close together and which can cause compromise of plaque shift or thrombus movement in the suprarenal segment and maybe in the future occlude the renals or the SMA. If you look at this one, the suprarenal struts are very flimsy, and there's a wide gap between these suprarenal elements. So I think, so far at least, we have not seen any plaque shift or thrombosis of the SMA or celiac or compromise of the visceral segments with this particular device. There's a big discussion between suprarenal fixation and fixation at the renals. So if you look at the Triovance device, it has both. But I think fixation is a key. You know, devices like Anurex, the Achilles heel of Anurex was migration. It was known for migration. And now we are fixing all these migrated stent grafts. So fixation is very key. Now, whether you do it with a suprarenal segment or whether we do it hooks or bobs or even endo anchors, you need some sort of fixation for the device to stay there so it does not migrate.
Dr. Amaya, did you say you did a renal chimney like this?
Yes.
Can you talk? How'd you do that?
Pardon?
Did you, so you put the rings up over the renals and put covered stents in the renals?
So you can do, the thing with chimneys, and I know this is a little off-label talk, but with chimneys is you get what's known as gutter leaks. So because you have two stents and this graft has to mold around those stents, and if you have technology of these wide metal struts and fabric, that molding doesn't occur very uniformly, and you can get a type 1A endoleak through these gutters. So I think with sealing technology like this, as well as with the Nelex device, Matt Thompson is doing a lot of chimneys with the Nelex device right now, putting it right above the renals and putting two stents in the renals. So polymer technology may be a way to seal the gutters more effectively than the configuration of metal framework and fabric.
Mickey, I agree with you that this technology is probably ideally suited for taking away some of the gutter issues, but I still would be a little concerned about all that suprarenal hardware and the impact it might have on your parallel grafts.
So far, it hasn't really affected that suprarenal segment because the struts are pretty wide, and you can even get through the SMA through those struts. But that is the disadvantage of using any suprarenal for that matter, is in case the neck enlarges in the future, then you have to go through those struts to get in your fenestrated grafts or to get in your chimneys. Yes, it's a concern, but I think fixation is very important, whether it be suprarenal or infrarenal. If you can make a device that fixates right at the level of the renal arteries, like the Triovance device has suprarenal and hooks and bobs. Gore has hooks and bobs right at the level of the renal arteries, which is probably the ideal way to fix an endograft, like suturing it right below the renal arteries. So if you can fix it at the level of the renal arteries, it's probably the ideal technology.
I agree with you on that. Let's get back to this case, though, because we're kind of getting off.
So now what has happened is the polymer has delineated the limbs of the endograft, and now the challenge is to get your catheter and your wire through that gate or the contralateral gate. Syed, what are you doing?
Trying to get this thing to go in.
So Syed, just FYI, you don't have to on purpose take 14 minutes to the cannulation, you know. We can also come back later once the 14 minutes are up.
Yeah, if you want to do that, that might not be a bad idea.
So one of the things we can do is we can break for a little bit, give another talk, allow you to work a little bit, let that polymer go in, and then we'll come back in about 10 minutes. Does that work for you?
That sounds good.
All right, what do you think, Paul? Should we just do that?
Yeah, that's,
okay.
That sounds like a good idea.
All right, Syed, work away.
All right, moving along the agenda here. Once again, we are honored to have one of our distinguished faculty members here, which everyone knows, I'm sure Dr. Thomas Shimshak is going to come and speak to us about the topic of, is endografting the ideal tool for the management of complex aortic iliac occlusive disease? Tom?
Thank you, Paul, and thank you again for the opportunity to participate in the meeting. Unlike the other speakers in this session, my talk will deal with a different application of stent graft therapy That's for non-aneurysmal disease, aortoiliac occlusive disease. Now, this is a list of my disclosures. The pertinent disclosure for this talk is the fact that I have a relationship with Endologix, which is the device that I'll be discussing, and this is also an off-label use for this particular device. So what is the current state of treating complex aortoiliac occlusive disease? Typically, it's not uncommon to have concomitant disease of both the distal aorta as well as the common iliac arteries to a varying extent. Chronic total occlusions are often present. There can be varying diameters of the aorta itself as well as the common iliac arteries, which present additional technical issues. Currently, there's no dedicated device that's currently available for this specific indication. We have a variety of endovascular tools and strategies that we've used over the years. Each, I would argue, has some form of technical and/or clinical limitation. The classic approach to treating aortoiliac disease is kissing balloons and/or stents, whether you use a bare balloon expandable stent, self-expanding stent, covered stent. This has been the classic treatment. And then some stent deployment of the distal aorta, whether you top hat or extend the stents up into the aorta. The limitations of this strategy is that there has been demonstrated decreased patency in more complex lesions, particularly those that involve significant portion of the distal aorta, and the aorta itself may not be adequately covered by this strategy. Patency of the kissing stents is further limited when there's mismatch of stent size, whether it's undersize or oversize, as you can see depicted by both nitinol and non-nitinol stent platforms. And then there's always this recurrent issue of the stents abutting against each other, potential luminal compromise, and extending the bifurcation up into the aorta can lead to crossing of the stents and present additional technical issues for the future. The Endologix stent graft is a unibody design which has been approved both percutaneous as well as open access for treating aneurysmal disease. Its deployed position sits at the anatomic aortoiliac bifurcation. It comes in a variety of sizes and diameters, and for a stent graft, it's relatively low profile, 17 French sheath compatible. To date, its role in aortoiliac occlusive disease has not been formally evaluated. The theoretic advantages of this platform for aortoiliac occlusive disease is that it encompasses the full extent of disease. It preserves the aortoiliac bifurcation. The fabric allows for significant oversizing of the nitinol support without wrinkling or infolding, and it does not preclude future aortic iliac interventions, whether it's contralateral, infrainguinal, or for more complex structural heart procedures, such as TEVAR. The covered stent also confers a relative advantage in terms of protection, potential for rupture for heavily calcified iliac arteries, mitigating distal embolization as you're treating this complex disease subset. So I have the pleasure of reviewing with you the initial experience of 9 participating centers who were interested in pursuing this technology for this specific indication. This was an IRB-approved retrospective review. We were treating non-aneurysmal disease, and I will review the procedural, technical, and clinical results of this strategy. These are the participating centers. This group of physicians consists of vascular surgeons, interventional radiologists, and interventional cardiologists throughout the country. The mean age of patients was 68, 64% were men. You can see that only 1.7% of patients had some form of aneurysmal disease, so this was really an inclusive population. And the majority of these were ambulatory with limiting claudication. This is their patient characteristics, a typical cohort in terms of risk factor and comorbidities. And this is the distribution of lesion types. As you will see, the great majority had type C, type D, complex aortoiliac disease that was treated. 33% of patients were deemed unfit for open repair based on other comorbidities and their complex anatomy. So let me share with you a couple of case examples. This is a typical patient with complex disease involving the distal aorta and disproportionate involvement of the right common iliac artery. This was treated, pre-treated, and then stent graft was deployed, and this is the graft as it sits at the bifurcation, and this is the final angiogram. This is a more typical patient. This patient had previous stenting of both common iliac arteries. You can see that there's some crossing of those stents. Both common iliac artery stents were chronically occluded. There was also involvement of the distal aorta, so complex disease. Both limbs were recanalized. The aorta was recanalized, pre-dilated. The graft was deployed percutaneously, and that's the final angiogram on the right. So using this strategy, our technical success was 96%. Almost all patients had general anesthesia. 63% had non-percutaneous access in this early experience. Blood loss was 195 cc's, and hospital stay was out to 3 days median. These were more complex procedures, and procedure times reflect that, as does the corresponding procedural fluoro time. In terms of adverse events, the leading adverse event was groin infection with surgical access. These patients were on ventilators, and 6% of patients had respiratory failure. The remainder of the complications were dealt with clinically without additional intervention. Iliac rupture occurred in a few patients, which were treated at the time of the procedure with covered stent grafts. The majority of patients had significant improvement in their functional capabilities. Over 80% have improvement between 3 to 5. And we look at the need for adjunct procedures. We can break those out into two categories: endovascular procedures and surgical procedures. 51% required some form of endovascular procedure. Most of these were either an additional stent within the aorta or extension of the graft in terms of the common iliac arteries into the external iliac arteries. So 19 patients had extension. There were 18 patients that had some form of relining of the graft to overcome inadequate radial force of this graft. 26 patients required some form of surgical intervention. Most of those were planned procedures. Common endarterectomy was the most common, and 3 patients had planned bypass surgery. Secondary interventions were relatively limited, 6% of patients, and most of these were iliac stenting that occurred in the follow-up period. When we look at freedom from secondary intervention at 1 year, it was excellent at 92%. And we look at patency of the graft out to 1 year and 2 years. At 1 year, 94%. Primary assisted patency, 96%. In the 16 patients that were followed out to 2 years, the primary and assisted patency was 100%. So to answer the opening question, is endografting the ideal tool for the management of complex aortoiliac occlusive disease, and specifically with this graft? I think the results are intriguing, but probably too early to tell. This initial experience does demonstrate some favorable attributes of this device. This retrospective review demonstrated high technical success and procedural success, even in very complex disease, Task C and Task D. The device does have inherent design features that are advantageous for treating this disease. The procedural review demonstrated a low 30-day mortality and procedural complication rate. Primary patency rate at 1 year and 2 years was excellent, and freedom from secondary intervention was 92%. In addition to demonstrated effectiveness, this device, the bifurcated stent graft from Endologix, preserves the anatomy of the aortoiliac bifurcation. There are limitations of this graft, however, in its current state. It's relatively large, 17 French and 9 French sheaths for the contralateral limb, and many patients have access issues that limit your ability to do this. The aortic component is relatively long, especially if you're dealing with just distal aortic disease, so you're sort of over-treating to a certain extent. Probably the biggest limitation of the current device is the radial force of the graft. This graft is not designed for occlusive disease, so to a certain extent we're pushing the envelope. There is risk of embolization, just introducing the device in this complex vascular bed with a lot of plaque material. Just bringing the device in can lead to embolization. It does require a higher level of endovascular skill, and there's always the potential for coverage of collaterals. And probably the other biggest consideration for this device is the cost, although that may be a relative limitation depending upon the alternatives in terms of how you treat this with traditional state-of-the-art therapy. We've demonstrated that there is often the need for adjunct therapy. Iliac stents are probably the most common, which potentially could be overcome with modifications of the current design, and access issues can be a problem, although more recently most of these procedures are being done percutaneously. So I think this is an intriguing experience. I think that it's something to consider in selected patients, but I think if it's going to be sustainable, there has to be modifications in the current device. Thank you for your attention.
Thanks, Tom. That was a great talk, and I would like to echo your comments and interest in this particular therapy for aortic occlusive disease. In fact, I routinely use it when there is occlusive disease combined with aneurysmal disease whereby the aneurysm is not quite large enough to warrant intervention, but we have to treat the occlusive disease. And you know that natural history of that aneurysm is going to be growth, so I've used this on several occasions. I agree with you. All right, moving on. How are we doing down in Urbana-Champaign there, Dr. Sia?
So we're getting the contralateral ligament now from the left side here. So we got cannulation done. We have to switch our catheter out. We use a little bit different catheter, get it in, and worked out really nice. So now we're getting the contralateral ligament. Now remember, the polymer is still curing. So this allows you to cure the polymer while you're working on cannulating the gate, getting the other limb in, and all that kind of stuff. So you're able to continue working despite the fact that the polymer is curing. So you're not really losing any time per se in doing the case. So here's the standard way, just a pin pull system.
Syed, did you do another aortogram to see that the hypogastric, or did you just go back to your initial position? Because I do know
I just went back to my original photograph, so all the lines are lined up nicely. So I try to minimize it. You know, if you don't change the II depth a whole lot or during the case or anything like that, then you can pretty much move the II side to side and not really run into a problem with your marks. In this particular situation, I know I'm exactly where I need to be because I'm in the pre-intervention angiogram settings, and I'm also, I can see from my black lines that I've made on the screen exactly where everything's lining up to be, so I know that I'm back to where I need to be at. So I usually tend to avoid shooting multiple angios during the case. You know, a lot of these patients have renal insufficiency and things of that nature, so we do a half and half contrast mix, so we do about 50% contrast, 50% saline for all of our injections. So usually we're able to do this case with usually about 20 milliliters of dye the entire case, 20 to 25. So I'm putting the 12 French sheath back in on the left side here, so that's what you see going in. And then what I'll do is, usually in this particular situation, we don't like to use a coated balloon catheter up in the limbs. Just because of the risk that the limb can actually slip out. So we tend to use a 12 by 40 balloon catheter, standard 12 by 40 balloon catheter for whichever company you'd like to use it from. And we do simultaneous kissing angioplasties after we got all the limbs in and everything. So this is the balloon catheter going up right now.
In your experience, Syed, when you have a long neck like you do in this case, and you ride the graft up to the renals, which means that your O-rings are really not advocated at the initial part of the aneurysm sac, but rather in a normal aortic neck. Have you seen in any of your cases that those O-rings, since they don't have the capability to expand, will actually constrain the lumen as they're inflating?
You know, that's a really good question. I've actually seen that happen a couple of times where when the rings go up and you shoot your final angiogram, the lumen actually looks a little smaller. So I have seen that. I haven't seen it to be of hemodynamic significance. I haven't seen any of the patients come back with a thrombosed aorta or any type of aortoiliac symptoms to indicate that they have some sort of occlusive problem. So it is something that I've seen on my angiograms after the graft's been put in, but nothing significant from a clinical standpoint.
Because my question
So-
at some point to some of the people from the company is, in those circumstances, should you then bring the graft down and have those O-rings be at the initial part of the sac? Vinky, what do you do in your case? You just write it up all the way?
Yeah, the idea
Yeah,
is to
so
get
what I do
seed-
usually is
Go ahead,
we
sir.
measure the aorta. So in this particular situation, we used a 26 graft. The largest portion of the aorta where we were going to land at 13 millimeters was measuring about 21.5. So we've oversized a little bit with the rings to make sure that we have a good seal up there. Theoretically, you could bring it down a little bit. Obviously, you're compromising normal neck and you're starting to go into aneurysmal neck. So we try to avoid doing that at all costs if possible. So I'm willing to accept a little bit of a smaller luminal channel that's not going to cause significant clinical symptoms, as opposed to bringing it down a little lower and increasing the risk for a possible aneurysmal dilatation or leak over time.
Well, again, it's a conceptual design, because if you have a nitinol framework with metal and fabric, the tendency is to have neck dilatation because nitinol expands over a period of time, the neck dilates. So there have been studies comparing nitinol technology versus polymer technology. So what happens to the polymer technology? So it does not create any outward radial force. So if you oversize this graft, say you put it a 20 diameter aorta and you put a 29 device, the tendency is for the polymer to encroach into the lumen, as Miguel said. So you can compromise the inner lumen of the aorta because of oversizing of this polymer technology. So you have to size your graft right. And a lot of times we've seen this. It almost looks like your neck is being constricted with this polymer technology. And so if you oversize it, yes, you'll get into this sort of problem. But in the majority of cases, there's been no flow lumen compromise of flow dynamics disruption with this. If you think it does happen, and we've done irises through this, and we've done pressure gradient measurements across this, the sealing rings, and they are not of any hemodynamic significance. If it does happen, then you may have to balloon it, one, and two, you may have to put a Palmer stent in.
So, Winky, with that in mind, are you a little less reluctant to use this device in patients with relatively small aortas with long necks, particularly women?
Not really. You got to size it accurately. So if you have a 19 or a 20 millimeter diameter of the proximal neck, then you use a 23 device, not a 29, oversizing it too much, which would cause encroachment of the lumen. So I don't think it's a contraindication or any concern. You have to just size the device properly.
Yeah, I think ultimately it comes down to sizing. Sizing is definitely very important. And the nice thing about this device, just to echo what Dr. Ramaya said, is to basically keep in mind that this polymer exerts very little atmospheric pressure on the aortic wall. So from a theoretical standpoint, this graft should not dilate over time. The aorta should not dilate over time. And you can see multiple studies that have been done, and I'm sure Dr. Ramaya may have commented on that over the last few years, that has shown self-expandable stents to cause some aortic dilatation over time. And so that is a concern for suprarenal aneurysmal disease to occur over a period of 3 to 4 years if a self-expandable stent model is used.
So there was an old device which was called the LifePath device, which was made by Baxter, and that had in its proximal a balloon expandable stent as part of the proximal neck sealing mechanism. And in that particular case, there was not much of neck dilatation over a period of time compared to the nitinol stents that are used in the other endografts. So that configuration, that architectural design may be a little better than using nitinol self-expandable stents that dilate the neck of the aorta over a period of time.
So, Saeed, how are we doing there? It looks like you're about ready to wrap it.
Pretty good here. We've got the polymer. We've got both of the limbs in now. So what we'll do is we'll use a 12 by 40 balloon catheter that I spoke earlier about to dilate up the limbs simultaneously in a kissing fashion. And that'll help to do our post-stent angioplasty. And then once we do that, we'll shoot our final picture and we should be good to go.
So, Binky or Syed, would it be a concern that, these patients, they have AAAs because they have problems, with their aorta, and the neck or infrarenal neck segment that tends to degenerate down the line in these patients is not always related to an endograft. This happens it's the natural history of people that don't have normal elastin. And hence the reason why open AAAs we do with as close to the neck as possible to provide, to avoid those late degenerations. What would happen if a patient like these were to have some, dilation of that neck where this O-ring will not have the capability to actually oppose by self-expansion? Would we get into troubles then? And what could be bailouts for those situations?
Well,
Yeah, so Dr. Amaya could probably comment on this as well. That's an interesting question because that is something that has not been really seen with these grafts over the past 5 or 6 years that they've been implanted in. If you look at the pivotal trial that was done as the initial trial for this graft, it didn't show any significant aortic dilatation over time 3 years out. And so, most of the dilatation that we're seeing in the self-expanding stent category has been occurring right around 3 to 4 years after the grafts have been put in. So, and the sizes are incremental. It's not like you go from a 26 to a 29. You see small 1 to 2 millimeter increases in size over a period of 2 to 3 years. And so I think in this particular situation, time will tell. We're going to have to look at what these grafts are doing 5 years down the line to get a better idea and see, is there any evidence of aortic neck dilatation in this situation? I think if that were to happen with this graft 5 years from now and there was a type 1 endoleak, one of the things you can plan on doing is you can use a Palma stent in this particular situation to try to tack up the top fabric, which is the first 7 millimeters of the fabric. So that would be an option to try to preserve your anatomy down below, or potentially you may have to snorkel and extend the graft up.
That was what I was going to ask.
Dr. Meyer, do you have any thoughts on that?
Can you could add another cuff, or do they make a separate cuff that you could extend north?
Well, neck dilatation can be iatrogenic from your endograft, or neck dilatation can be part of the pathological procedure of the aortic wall itself. If it is degenerative disease of the aortic neck secondary to the patient's morphology or pathophysiology, then it will happen no matter in which endograft you use it. So if it does happen, then yes, you will have no more seal and you'll have a type 1A endoleak. So in those cases, the way to fix it is to put a cuff, though this particular device has no cuff to be placed, so you'll have to use some other device, or you'll have to snorkel, put chimneys, or use a fenestrated graft and build upwards. But if it is related to the pathophysiology of the patient and the atherosclerotic process of the proximal neck, then it can happen in any device that you use. But you don't want to make it happen by outward radial force and make it an iatrogenic process.
Wasn't that what happens when you put the Palmas in? There's some radial force.
Yes. Palma stent is not a self-expanding stent. So the Baxter device had literally a balloon expandable Palma stent in its proximal neck, and the Palma stent does not dilate over a period of time compared to
You're going to dilate it.
On the right, yeah. So we're going to go ahead and take the balloons out here. I tend to use a coated balloon catheter for the iliac limbs below. We'll go ahead and do that now.
So it looks like you're about ready for your final angio.
Almost, yep. Ready to go here in just a little bit. Just going to balloon the bottom end with the coda catheter, and we should be set to go here.
So the question for the panel is, do you routinely balloon the proximal neck after you place an endograft?
100%.
I generally do as well, even if it's just gently, just to get the folds out and what have you.
I almost never do.
Hold the sheet, please.
So you balloon the proximal neck with a coda balloon?
Yeah, I just use the coda there just to kind of tack it a little bit.
What's your thought process for not using the same one you used up?
I don't know, just choice, I guess, and habit over time. You probably could use the 12 millimeter balloon up there. It's only a 12 millimeter diameter balloon, so it may not get a real good angioplasty with seal up there, so.
All right, you got 50 seconds.
take a picture on my side. Typically, you shouldn't have to balloon the proximal end at all. The nice thing about the rings is that once you see the squaring of the rings like you see up there, you theoretically shouldn't have to do any ballooning at all. It should just get a good seal up above. So, you go ahead and do that balloon.
Hey, you got some friends in the back because your timer was 50 seconds and all of a sudden it went back up to 2 minutes. I'm sure you know people that know people here because I never got that break yesterday.
Forward, please. 15 for 30, what's that? 15 for 30. 2 syringes, please, 2 big ones. Injectors ready. Left hole. Looks like we got a small little type 2 endoleak there. Otherwise, looks pretty good. What do you guys think?
We all agree. Fantastic result there, and an excellent demonstration of the trivascular device.
Tell your cameraman to zoom out and show us the left renal.
Yep. I assume it's pretty good on your screen. Yeah, there you go.
Thank you, cameraman.
Very nice.
Good
Yeah,
job.
he does have a type
All right,
2
thank you,
endoleak. You
everybody.
can see 2 lumbars over there, and you can see it fill the sac.
You can see the lumbar coming off the hypo right there, coming around, so.
But nothing to do.
Yeah, again, I think
Yeah,
that's all
obviously
considered a
don't.
successful outcome here.
Good job, man. Thank you for showing us that.
Thank you. Thank you, everybody.
We're going to move along on our agenda here, and I am always honored to present our next faculty member, who is not only a dear friend, but has been a mentor to me over the course of the years and actually trained me on EVAR way back in 2001, I believe. And Dr. Zvonimir Krazier, who I'm sure everyone knows, he is internationally renowned, particularly in the area of EVAR, and was the true pioneer in the percutaneous management and treatment strategies for not only EVAR but also TVAR. Dr. Krazier comes to us from the Texas Heart Institute, and he will be talking to us about improving outcomes in highly angulated AAA anatomy with an on-label solution. Franco?
Thank you, Paul. It's a special pleasure to be here again. I hope that Hussein didn't take some of my time away from doing unnecessary angioplasty, which is not needed in this stent graft in 90% of the instances. Here are my disclosures. One of the pertinent ones is that I do courses for Lombard Medical. There will be mostly talk related to that. When we ask ourselves what are the unmet needs in challenging anatomy, obviously there are multiple, and Dr. Ramaya mentioned that very clearly with current generation stent grafts. One of the major ones that we are always worried about is endograft conformability, particularly in tortuous infrarenal neck and also iliac anatomy. Now, there are numerous publications, information available. Here I listed 3 of them for you. As far as predictors of type 1 endoleak and the need for reintervention post-EVAR, and you can see here that neck certainly plays a significant role, particularly when the neck is short, but there are also other factors such as severe neck angulation, and sometimes you have a combination of those two, and many other ones such as thrombus, calcium, and combination of those things. Now, look at the hostile proximal neck challenges that we deal with as far as EVAR is concerned and the effect of this on durability. Antonioni, in his meta-analysis of 7 major studies, compared different type of stent grafts in hostile versus normal or friendly neck anatomy, with a variety of stent grafts. You can see Endurant, Anurex. Some of them are no longer available, actually. Excluder, Zenith, Talent. What he has found out, the type 1 endoleak is 4.5 times more likely at 1 year of follow-up if you have hostile neck anatomy. And also the aneurysm mortality risk goes significantly up when you are outside of the IFUs. Now, Schanzer and Greenberg look at analysis of over 10,000 patients in U.S. multi-center studies and look at particularly on the aspect of use the device on label versus off label, and also in challenging neck angulation. And interestingly enough, and this is not surprising to most of us because we have ventured into no man's land in this certain area, only 42% of patients in this analysis had neck anatomy within IFU. So it means that we violated that criteria very, very frequently. But what happens when we do that? They found that, among other things, bad things, that 41% of those patients that were outside of IFU had progressive neck enlargement at 5-year follow-up, which means trouble. So what about iliac anatomy, particularly as far as unfavorable iliac anatomy? And Albertini looked at 157 patients with different type of stent grafts, as you can see, Zenith, Paralic, and Talon stent grafts, with tortuous iliacs, aneurysmal iliacs, calcified iliacs, and combination of those things. And he found that 17% of patients in this type of anatomy had type 1B endoleak, and 8% of patients had iliac limb occlusion. So his conclusions were the aneurysmal extension to the iliac bifurcation and beyond increases complications and secondary procedures during follow-up. Now, lumbar stent graft was designed with this purpose in mind to treat the very challenging infrarenal neck and iliac anatomy. The device was approved in February of 2013, and it has unique features, and one of the most important unique features is that this is the only endograft designed and approved to treat highly angulated, extreme infrarenal neck angulations, all the way from 0 to 90 degrees and beyond. It consists of a polyester material and densely arranged nitinol rings that seal and add a radial force at a sealing zone very effectively. It has excellent conformability, particularly when you're dealing with very tortuous infrarenal neck and iliac anatomy. It has a very flexible columnar strength, and the limb shortness is possible in case you choose a device that's longer than absolutely necessary. It has a unique helical design of the stents to keep the vessel patent, even in the most tortuous anatomy, as you have seen here with very tortuous iliac arteries. Here you can see some of the results, how the device conforms very well to severe neck angulation without any risk of kinking or obstruction. And also the device straightens over a period of time as the very short and challenging infrarenal neck remains sealed. Now, the clinical trial that was a pivotal trial for this particular device was US Pythagoras clinical trial, which was the first EVAR trial anywhere in aortic neck angles from 60 to 90 degrees, which is totally outside for most of the commercial available devices as far as IFU is concerned. It enrolled 218 patients with intention to treat. The rolling group was a little bit less aggressive as far as angulation is concerned. That was 67 patients. And then the primary study group of 151 patients had angles of the infrarenal neck between 60 and 90 degrees and higher. And the control arm was SVS registry meta-analysis of patients that had procedures done. And that was in 323 patients. So as far as demographics are concerned, comorbidities, anatomy is concerned, AORFIX high-angle group differ from the control group in regard to the factors that would adversely affect the procedural and also long-term outcomes, particularly as far as the neck angle is concerned. And AORFIX was an average 83 degrees versus 48 in the control group, and the neck angle of more than 60 degrees in the study group. The AOFIX was 69 versus open 27. So this was the first trial with more severe neck angles in the test group of any studies available. When we look at the EVAR-specific results at 30 days and also at 1 year, we can see that regardless of the angle, whether it's a mild or a more severe angle, freedom from SVS defined major adverse events at 30 days. It was significantly lower than in the control group. And also when we look at the other study parameters as far as mortality, sac shrinkage, sac expansion, type 1 and 3 endoleaks on migration, it was basically similar between lower angles and very high angles. And even at a 2-year follow-up, we can see that the results performed very well in comparison with the control group as far as major adverse events, but also as far as the other parameters, studied parameters are concerned for all angle degrees. Freedom from secondary interventions was also very, very low and didn't change over a period of time, even after 6 or 7 years of follow-up, which is very encouraging. Now, when we compare the performance of this stent graft with other commercially available devices, we can see as far as freedom from major adverse events is concerned, it's very comparable to those that treated challenging neck anatomies of 60 degrees or higher. For most of the commercial available devices, this is not within IFU, so you cannot compare that. And mortality was also comparable and low in comparison with the other devices as far as diameter reduction, diameter expansion, type 1, type 3 endoleak is concerned, and migration is concerned, again, very comparable to the other commercially available devices. So, in summary, the Pythagoras clinical trial of the AOFIX endograft was the first EVAR pivotal trial focusing on highly angulated aortic necks from 60 degrees to 90 degrees and higher. And despite the predictors of worse short and long-term outcomes, major adverse events are superior to the open repair, and EVAR-specific outcomes are similar to trials within much less severe anatomy. So, based on the Pythagoras trial, AOFIX was FDA approved for treatment of infrarenal neck angles from 0 to 90-degree angles and remains the only approved on-label alternative to open repair for patients with highly angulated aortic necks. Thank you very much for your attention.
Marco, thank you for an excellent presentation. At this juncture, we're going to kind of open up the session a little bit for questions for our panelists. Again, we have some really, truly international experts here and just a host of experience on EVARs and aortic aneurysm interventions here of the members of the panelists. So the door is open, the floor is open for any questions for our panelists.
Earlier there was discussion about iliac disease being treated with a AAA device. If you have in-stent restenosis from a kissing stent, what are the options there? That seems to come back a lot if you just use cutting and other kinds of device. I mean, you reline that with another stent. Do you use a covered stent? Do you use a AAA device? What do you do there?
I wouldn't necessarily go to a bifurcated stent graft as your first line of therapy. I would try to use conventional therapy to treat that first, but it depends on where the disease process is. If it's confined only to the iliacs, I would use balloon angioplasty and potentially reline that with a different stent graft, maybe a covered stent, balloon expandable stent, but confine that just to the aorta. Or you could use just a bare stent as well. But once it begins to involve the distal aorta, then I think that you sort of have taken a leap in terms of complexity. the more localized it is above the bifurcation, potentially the easier it is to deal with balloon angioplasty, or maybe a slight extension of the kissing stents. But if the entire distal aorta is involved, then I think you need a more definitive therapy, maybe an additional stent in the aorta itself, and then reconstruct the bifurcation. But once you commit to that, you're sort of altering the intrinsic bifurcation anatomy, but that may be a price you pay. I would reserve the stent graft only for a more complex disease process at this point.
I'd agree with you. First of all, I would, in addition to the comments that Tom made, I would try and assess the situation to see why the stents restenosed in the first place, because usually well-deployed, properly sized stents in the iliacs, the restenosis rates are really relatively low. In the event that it is true restenosis, and there's no other problems with the smaller stents and what have you, oftentimes I would treat those with restenting and probably with a covered stent like the iCast.
Yeah, I would agree with that. And the only thing I would add to it is that if you kind of really have distal aortic disease that's kind of starting to encroach down, and then you have your restenotic stents, then I think if you have room, unibody graft, analogic graft makes some sense. But it can be a little challenging. If those stents are riding a little bit high, and it's a little harder to do that, you have to be really careful.
What about some of our surgeons? You guys want to comment on in-stent restenosis and management in the iliac disease?
Yeah, I think the pattern of in-stent restenosis has to be determined too. It's not the same if you're doing primary assisted patency, if you're doing secondary patency, or if this is a frequent flyer that has come now for the second or third intervention. Normally for the first timers, if you can debulk and just balloon angioplasty, make sure that you have adequate wall position and anatomically looks good. Iva said make sure that everything's fine. Usually those do really well with that one first attempt. If it becomes a bigger issue and there's more of these other things going on, then I know that probably the permeability of whatever I do is going to be not adequate with just a plain old balloon angioplasty, and that's where I would consider probably using PTFE covered stents after debulking as a way to reline the structures.
I think IVUS is a great tool to assess the restenotic process, because often what you'll find is that the stents were misplaced initially. There was disease that was missed at the true ostium, and you can learn that by doing IVUS.
I agree 1,000%. Wonko?
I don't think I have anything else to add.
Hey, I have a question for you, Thomas. That 50% additional interventions in that study, was that acute? That was like during the procedure? That wasn't adjunct later on? Acute. Okay.
Are you just meaning that, was that just, I mean, you say unplanned, or was it beyond the endograft?
No, I think it was a little bit of both. Half were an extension, but the other half was due to inadequate radial force of the device at the iliacs, where there was excessive calcium and you just needed greater degree of scaffolding.
Oh, so it was adding some scaffolding mainly, not like there were new other things.
Right.
Within
but the beauty of the strategy, even though it required additional devices, the reality is that we didn't have to reconstruct the bifurcation per se. The stents were deployed within the body of the common iliac artery, sparing the ostium.
I saw that you had Michael Reinen from the Netherlands, I think, right, Michael? And he's a very large advocate of this procedure he calls the Johnny Walker, where you put an iCast, because Europe has the bigger iCast, the 16, 18 millimeter iCasts in the distal aorta, and then writes 2 iCasts into it. If you had that, and if we had that FDA approved, would that make you change your mind, or would you still pursue the endograft? Yeah,
I think one of the limitations of our current device availability is that we don't have, an ideal component for the aorta itself. I think if you had that, that's an advantage. But then I would also try to preserve as much as you can the anatomic bifurcation. I think that's the key, because many of these patients will come back with infrainguinal disease that you want to be able to go contralateral. So I think as more often as we can preserve the bifurcation, but still adequately treat. I think that's the goal of the therapy.
Again, I think the concept is very attractive, but the device is not ready yet.
Yeah,
So if you can make a device lower profile with a bifurcated system, change the design concept of it, because the endologic's radial force is not very good for this kind of occlusive disease. But the concept is very attractive to treat aortoiliac disease by this method and preserving the aortic bifurcation. So the concept is very good.
Venki, I absolutely agree with you. The concept is great. The rest of it stinks. So the thing is, in my experience with this type of a scenario, it works very well when you have occluded one iliac and you have to recanalize it. And I use an 8 French sheath for most of the cases. Right. It's a low profile for CTO, and it works very well. But in many other scenarios, you have issues there. Now, another thing is, it totally shocks me that 98% of those patients were done under general anesthesia. And a significant number had absolute contraindications to surgery, which means those were sick patients, a lot of comorbid conditions. I mean, I just don't understand why this would be done. I don't remember the last time I did a patient under general anesthesia. And then there were a lot of them done surgically. You had all kind of complications related to it, including infection. Boy, that's a high rate of infection. This study, to me, needs to be redone better, much better.
Any additional questions?
Do they have FDA approval for that indication? Is that what they were pursuing with this?
No, this is just an initial experience for testing the application of this technology for that indication.
So Dr. Krazier spoke about the AR fixed device. Again, for highly angulated necks, if you look at most of the currently available devices, the neck angulation has to be less than 60 degrees. So if you have a neck that's really angulated, then the AR fixed device is probably the best device to use. But again, if you look at the architectural design of the AR fixed device, it's like a slinky. And it's very hard to compress a slinky. So the profile of this device is what's a little concerning, because it's almost a 22 French. So that's pretty big when you have devices that are 12 and 14 French OD. So I think that concept, again, to make it smaller, I don't think you can make the device any smaller than probably a 17 to an 18 French. What do you think, Craig?
Yeah, you're right. So interestingly enough, in the Pythagoras trial, a significant number of patients were females. And females have smaller arteries, so it worked well in a lot of scenarios. But the profile certainly is an issue for certain subgroup of patients. There's no doubt about it. The next generation device, I don't know when it will be approved, probably early next year, if not this year, will be 18 French. So that will make significant improvement. There's no doubt about it. But it really conforms very well to the most challenging anatomy and has a very good trackability. So it definitely has advantages. Like you mentioned, Venki, we have 6 devices available. There's no ideal device. But you cannot be stuck with one device if you're going to be an expert in the field. You have to be good with all the devices, because each device has certain idiosyncrasies, advantages, and disadvantages. And you just have to know how to use them well.
I totally agree, and that's why you need to be up to date with all the new technology, especially as you treat more and more complex cases. Some devices will outshine other devices.
All right, guys, I think that's all the time we have. Thank you to the panelists and our audience. We'll go to a short break, and we'll come back, 10:45? No, 10:22, right? 10:45. Thank you.